Yeah, so as an ocular oncologist, your primary goal is always to preserve life, and the secondary and the tertiary goals is preservation of eye and vision, which, of course, if you're able to preserve, it's always a bonus. So, starting with the conjunctival tumors, the first and the primary thing in conjunctival tumors is to determine the extent, because the conjunctival tumor not only involves the epithelium of the conjunctiva, it can you have to determine the entire extent of the epithelial involvement. It can extend into the stroma, into the corneal epithelium, into the corneal stroma, into the orbit, and also it can spread to the lymph nodes. So determination of this kind of spread is always important. So when you're looking at a conjunctival tumor, the primary thing is to determine whether it is benign or malignant, whether there is any need for surgery, what is the likely histopathological diagnosis, and whether any adjuvant therapy is necessary. So for any benign tumor, unless the patient is absolutely not willing, you can do an excision biopsy with a 2 millimeter margin and do a primary closure. For a malignant tumor, it's always important that you determine the extent of the lesion pre-operatively, because a conjunctival tumor can look completely different on slit lamp examination and intraoperatively under a microscope. So having this kind of a diagram in the operation theater is very important. So for a malignant tumor, especially in OSSN, a no-touch technique is followed, where the entire conjunctival tumor is resected, and then the corneal component is resected. The resected conjunctival edge is treated with adjuvant therapy of double freeze thaw cryotherapy, and also you can also give some amount of cryotherapy to the base of the tumor, which is generally located at the limbus. And then the construction of the surface can be done either using flaps or grafts, and grafts most commonly used is the amniotic membrane graft. Once you submit the resected tumor for histopathology, you must always ask for whether there was any margin or base positivity, because if there is margin positivity, generally you need to treat adjuvantly with interferon or mitomycin therapy, and if there is a base positivity, you generally need to treat with the plaque brachytherapy to minimize the chances of recurrence. In contrast to ocular OSSN, a conjunctival melanoma is a purely surgical tumor, meaning once you have resected the tumor, and if there is any base or any edge positivity, you never go back and do any cryotherapy or interferon or mitomycin therapy. You always go back and resect the positive margin, so that the entire tumor conjunctival surface is absolutely rid of all melanoma cells. Moving on to eyelid tumors. In eyelid tumors, always expect the unexpected, because what can look like an ugly mass like this, which is lobulated and quite, vertically and horizontally quite extensive, can be benign, as you see in this case, which is an eyelid papilloma. And what can look like a flat lesion with some amount of ulceration is actually a malignant tumor, and this is basal cell carcinoma. As you can see, there is absolute loss of eyelid margins, there is madarosis, and there is multiple points of ulceration. So when it comes to an eyelid tumor, one thing during surgery you need to keep in mind is you need to have a 4 millimeter margin not only on the skin surface but also on the conjunctival surface. This holds true even if you're doing a pentagon excision, or whether you're doing a cutler beard technique for which you require a rectangular excision. So once the excision part is done, you have to send the sample for frozen section to determine that the margins are actually negative, and only after that you can do a primary eyelid reconstruction. Now when it comes to sebaceous carcinoma of the eyelid, the technique is slightly different. The treatment of sebaceous carcinoma is generally done as a two-step technique. The step one is determining the extent of the disease. The reason for this is the sebaceous carcinoma is very notorious for pagetoid spread in the conjunctiva. So some unseen tumor may be present in the conjunctiva from the eyelid. So always do a conjunctival map biopsy at around 16 to 18 points to determine if there is conjunctival extension or not. And then the step two, after determining the extent of the lesion, is to do a definitive therapy, and this is using excision biopsy and frozen section margin control. Moving on to the orbital tumors, one must remember that greater than 50% of the orbital tumors are malignant. Hence, almost all tumors actually require treatment, not only for the reason that it could be malignant, but also these tumors usually cause proptosis and disfigurement, and hence for cosmetic reason as well. So, for orbital tumors, like I said, almost all tumors need surgery. The choice of surgery and approach to the orbit depends on five important factors. What is the goal of the surgery? Whether you want to completely remove the tumor or only small part of the tumor. What could be the probable clinical diagnosis? Where exactly is the tumor located, the tumor size and extent, and what is its relation to the neighboring orbital structure, especially the optic nerve. So the stepwise approach for orbital tumors is to first determine what it could be, and this is based on clinical history, clinical examination, and imaging, that could be CT or an MRI. Then is to do a surgery. The surgery can be an incision biopsy, an excision biopsy, debulking or exenteration, and then determine histopathologically what the tumor is, and if needed, to give further specific treatment. The choice of surgery is incision biopsy when the probable clinical diagnosis is that it could be a malignant orbital tumor. So your goal here is to take just a small part of the tumor, determine what tumor it is, and then give a specific treatment. For example, in this patient who came with bilateral proptosis and some amount of palpable mass on the surface, I did an orbital imaging, and you see that both orbits are studded with small tumors. So the probable diagnosis was metastasis or lymphoma, which has a presentation like this. So all I did was an incision biopsy where I took just a small piece of the tumor, subjected it to the histopathology, turned out the patient had orbital lymphoma, and the patient underwent specific treatment with chemotherapy and orbital radiotherapy. The choice is excision biopsy when you know it's a benign tumor and you can completely excise the tumor without harming the neighboring orbital structures. For example, this patient who came with the right proptosis underwent an MRI scan, and this tumor is a schwannoma, a neurolemoma, a benign tumor. So excision biopsy was done in this patient where the tumor was completely excised and the patient did well. Debulking is the choice of surgery when it is a benign tumor, but you cannot completely excise the tumor without damaging the neighboring orbital structure. So you take out as much of the tumor as possible and leave the rest. So this is a patient with right eye proptosis who had on MRI a fluid level which is diagnostic of lymphangioma. Now lymphangioma is a very irregularly placed mass within the orbit extracornal and intracornal space. It's impossible to excise the tumor completely. So you do debulking of the tumor as much as possible and treat the rest with a sclerosing agent like bleomycin, and the patient did well. Exenteration is the choice of surgery when the tumor has gone beyond the orbital structures and has extended into the cranial cavity, or it is beyond, the eye is beyond salvage. Okay, so you do exenteration not with an intention to save the eye, not with an intention to save the vision, but to save life, which is our primary goal. So as you see in this patient who had a malignant orbital tumor which turned out to be a choroidal melanoma with orbital extension, we completely did exenteration and the patient did well. Moving on to intraocular tumors, the tricky part about intraocular tumors is that the tumor is not available for biopsy. So you cannot determine whether it is a malignant or a benign tumor. But then most of the tumors have a definite characteristic, the color and the location, and of course there is always a history. So based on this, you have to determine whether this is a malignant tumor or a benign tumor. And of course there is ancillary testing like FA, ICG, and OCT and ultrasound. Based on this, you can determine what the probable diagnosis could be. And whenever it is a malignant intraocular tumor, you must definitely treat the tumor with the principles attached to particular tumors such as choroidal melanoma, choroidal metastasis, retinoblastoma. Each have their own set of principles which is beyond the scope of this presentation. And a benign tumor which is not causing any harm to the patient in terms of vision or anything like that, you can just leave alone and observe. But a benign tumor which is likely to cause a problem to the patient, like retinal hemangioblastoma, which can cause exudates, it can cause CME, and it can cause deterioration of vision. Also, a retinal hemangioblastoma is associated a von Hippel-Lindau, which is a systemic syndrome. So such tumors definitely require to be treated, and the patient need to be examined. Otherwise, a benign tumor, intraocular tumor that is not causing any visual affection for the patient, just leave it alone and do watchful monitoring. Thank you.
Thank you, Dr. RAKSHA, for a wonderful talk. And as you said, oculoplasty surgeons should be prepared for surprises.
Absolutely,
They should hope for the best and be prepared for the worst.
That's
One thing I would
true.
like to ask you,
Yes, ma'am.
since you are practicing in NN, obviously you've talked of the most ideal things that should be done. What about so many government hospitals in India who don't have frozen section facility also at times on the table?
Yeah.
So what would you suggest them?
So yeah, what you can do is you can definitely do the excision therapy and excision biopsy and subject it to histopathology.
Yeah,
You don't have to do primary closure at all. Wait for the histopathology. After 7 days, when you get the histopathology, based on that, you can do the secondary closure. In the meantime, you have to be obviously very careful of the cornea to prevent exposure keratopathy. So lots of lubricants, lots of patching, and lots of advice to the patient.